I think we are there. Yes, indeed. Good afternoon. Top, top of the afternoon to you. I am Dr. Randy Fink, and it is 4 o'clock in the Mountain Time, which means 6 o'clock on the East Coast, and it is only time for one thing on Tuesday evening, and that is Fertility with Fink and Friends. I am Fink, and you are friends. Very happy to have everybody with us. Looks like Emily was the first one to join over here on this Instagram side, and gosh, everybody's pouring in over here. Amli and Lovejoy joined at the same time. Our first guests tonight. Thanks, friends, for being here. We've got two different Facebook two different Instagram streams, and we've got Facebook and YouTube down here. Well, I am passing through a very special town here tonight, and that is none other than Miami, Florida, for a very short little visit. And I am at well, you may know me as the director of IVF services at CNY Fertility in Colorado, but I am at the Miami Center of Excellence and CNY Fertility at the Miami Center of Excellence, which is a wonderful place to do monitoring and consultations on fertility, and that's where I am tonight. So we got a little different change of scenery that you can see around me here, and if you looked outside, you would see it's about 92 degrees, which is a little bit of a different situation than what we normally have in Colorado Springs. So Staley says, welcome home. Thank you, my friend, and thanks to Barbara for being here and for kind of being here as always. So good to see everybody. How's your week been since last time? We had some interesting. Hi, Brandis. Brandis has joined here on the CNY side. Lovejoy says hoping to see you next week. Great follicles forming. Ultrasound in the AM. Well, that is good news to hear, my friend. Good news to hear indeed. You know, it's been a great week as always. The weeks sometimes have different challenges. This week, some good friends of mine, patients of ours from the Colorado office are trying to deal with a miscarriage situation, which is really always a very hard thing to go through. It's a hard thing to go through under any circumstance, but especially after IVF when everything was, everything seemed so right and it was going so well, and to have to go through that process and then to end up with a pregnancy loss is really heartbreaking. And so, as always, I'd like to say for everyone who is out there who may be suffering tonight, who may be hurting, who may be really overcome with hope, but yet fear at the same time. Fear of what may happen tomorrow and hopes for what may happen tomorrow. I just want to say that our whole community is with you. We stand together as one to really join hands and be positive about possibilities for the future. So to all of those of you who are dealing with loss tonight and those challenges, again, our feelings certainly go out. Oh, Tiana joined me. Hello, Tiana. I can push the button that says wave here. Nice to see you. You owe me a taco. Well, let's see what else we have happening here. It's been really hot all around the country. If you watch the news at all, and you see that, boy, it's pretty miserable outside in most places. And I got an interesting question about, does that have an effect on fertility? Does the heat have some effect on our ability to get pregnant? And the way the question was posed to me, was an interesting one because, fortunately, we as a species, are not, I always say we're not so fragile that, heat outside is enough to really, ruin us, at least not at this point. We talk about global warming and all those other things that are happening to us. It's not that kind of situation, because if you look back upon us evolutionarily, we know that we lived in very hot times. We've lived in very cold times. There are people who live on the plains of Africa who have no roofs over their heads, who can't protect themselves from the sunshine or the nighttime or the animals or anything else outside. So, it makes us uncomfortable to say for sure, but even that kind of stress, the stress of being out in an environment that seems inhospitable or sometimes even inconducive to our species perpetuating, our species is able to continue. So I'd like for you to at least be optimistic on that front that I don't think the heat makes a difference, but it does make us uncomfortable. Now, then you could ask the question, well, don't we say that after doing something like a retrieve or after something like a transfer that you're not supposed to get in the hot tub and you're not supposed to get in the sauna? And the answer to that is yes, that's true, because when our core body temperature increases, this can potentially be problematic for the baby or the embryo that's growing on the inside. So by that same token, heat exhaustion or heat stroke, really our organs and our systems start shutting down when our internal body temperature, when our core temperature starts to exceed 106 degrees. And that's pretty doggone hot. There should be no good reason that your core temperature is above 106 degrees. And if it is, you're in a heap of trouble. Your kidneys and your liver and your heart, your cardiovascular system are going to start suffering that just as much as things about pregnancy. So certainly try to stay cool, especially try to stay hydrated in these very hot times. And that's probably the best thing that we can do. I think there's going to be some relief in sight, but they're talking about August being the hottest month on record. So we still probably have it worse before it gets better. On the Facebook side, Tamika is here. Good evening, my friend. Hello. Tamika's asking, what's the difference between estrogen and estradiol? Okay, fair question. My estrogen is 93. My AMH is 5.48. Regular period. My FSH is 8. I'm 38, and I want to know if that's a sign of PCOS. Well, Tamika, that's a very good question. So the difference between estrogen and estradiol, they are the same thing. Estradiol is a biologically active form of estrogen that we are able to test for in the blood. So when we do that blood test, we are looking for your estradiol. The estradiol level, that is the type of estrogen. The AMH level that you report at a 5.48 is probably indicative of ovaries that will behave like PCO or polycystic ovaries. When that AMH gets above about a 5, it starts making us think that your ovaries are going to respond pretty well and may have a tendency to hyper respond or potentially over respond. And that's the thing that we watch for in polycystic ovaries. Now, we use this term interchangeably, PCO versus PCOS. What's the difference there? Well, polycystic ovarian syndrome, I can do an ultrasound on somebody and I can show a bunch of eggs or a bunch of follicles rather in the ovary in a pattern that appears to be consistent with PCO. It kind of looks like a chain of pearls. And basically what that is a lot of little eggs in their follicles, in their egg houses that haven't been able to get recruited to fight for which one is going to grow and become dominant, or in the case of IVF, that haven't been stimulated to the point where those eggs are going to grow so that we can retrieve them. Well, that's what I would call PCO. And some people just the ovaries look that way, and you may have an AMH that is suggestive of polycystic ovaries. But PCOS, polycystic ovarian syndrome, is associated not only with that characteristic appearance on the ultrasound, but also with some other type of metabolic abnormalities, particularly elevated androgens or male hormones like testosterone. Now, this often leads to a clinical syndrome that may make it very difficult for you to lose weight. It may cause acne and hair growth in places that you don't want it, potentially even hair loss in the places that you do. So that's PCOS versus PCO, and I would say yes, that is suggestive, kind of based on those numbers. All right, let's see. And away goes Paige has joined us here. Thanks. Ruzik Blue, who I believe is my friend in Las Vegas. Am I right? Greetings to Las Vegas tonight. By the way, I saw, speaking of Las Vegas and speaking of the heat, I saw on the news, they had a reporter who had one of those, thermometers, the thermometer type gun thing. And they were on the strip in Las Vegas, and they pointed it at the cement. And the ground was 165 degrees on the ground, which is unbelievable. So imagine walking on that barefoot. There was the story of a man who got dizzy at the bus stop and sat down on the ground and ended up with third-degree burns over his back parts. And boy, it is just really hard to imagine that sort of thing. In any event, if Orlis's suppression made hormones go wacko with cysts and fibroids, never had a history of these, what other approach would you suggest before an FET? Well, so what we're talking about there is using medication to suppress endometriosis before doing an embryo transfer. Why do we need to do that? Endometriosis has this nasty habit of interfering with the way the brain is talking to the uterus. And so when we find endometriosis, or when we have endometriosis, suppressing or turning down the volume knob on that endometriosis results in better success with embryo transfers. So that's the rationale. The old way to do that was with a medication called Lupron, and it still really probably represents the ultimate, the kind of the gold standard. Lupron, which you may have used in some of your IVF cycles for differing things, in a long-acting form will actually sort of shut down the body's hormone production, like completely shut it down, which allows endometriosis to kind of, let's call it, dry up and blow away. Oralisa is an oral medication that we use to treat endometriosis. And it has the effect of turning down some of those hormones, but it gives back some hormones as well. So the biggest side effect, as you might imagine, from turning off all your hormones is that suddenly you feel menopausal, because what is menopause? It is that state where your hormones have gone away. Oralisa, so I'm not sure, wacko with cysts and fibroids. Hard to know really kind of what happened there. It may have been the portion of the Oralisa that was designed to minimize your side effects, to give you back some hormone, may have caused an effect there. But so the next step is very simple, and that would simply be to use a Lupron shot. So Lupron there's a short-acting Lupron that you can do on a daily basis. I wouldn't recommend having to get a shot on a daily basis. There's a once monthly depot Lupron and a 3-month lasting depot Lupron. When we say depot, that means it's a long-acting form, and so that's where I would go with that, my friend. There. This comes from Jay Milles. Looks like, any thoughts on recommendations to do a natural transfer without letrozole, but with trigger and an immune protocol? And I would say absolutely, positively yes to that. In most cases, for the natural FET transfer cycle, I'm not a fan of using letrozole, but let's think about what's really going on there. So in a medicated cycle, we are giving you all your medications. We are giving you all your hormones in order to affect the way the body is processing. We are controlling every aspect of those hormones. In a natural cycle, we're letting your own body contribute some of its hormones, which may have a slightly improved effect on your outcomes. So that seems like a good idea to me. Plus, it's less medication. You don't have to do the progesterone and oil shots, which is kind of a big thing. Your butt will thank you for it. Um, and but it is predicated on this idea that your body is going to make an egg, that you are going to develop a follicle that is going to continue to grow. Continuing to grow that follicle is how you make your estrogen. You are going to make your estrogen. That estrogen is going to thicken up your lining. So rather than having to use all that extra estrogen that we use like during a medicated cycle, your body's making it itself. When we see that the follicle is of a sufficient and mature size, we can trigger your ovulation, which starts the clock ticking on when you're going to have your transfer. So it gives us some control over that transfer timing. Some people opt to not use the trigger because if you ovulate on your own, then you don't actually need the trigger because you will ovulate, but it just gives a little extra measure of control. Our offices are not open for retrievals and transfers on Sunday, for instance. So if your natural cycle ends up meaning that based on when you ovulate, that your transfer would take place on a Sunday, it gets canceled and we have to move it to, on to the next month. If you don't ovulate, then using letrozole will make you ovulate so that you can do a natural cycle. But if you ovulate on your own, that is to say you have regular periods, your ovary releases an egg every month, there is no reason that you need to use letrozole. In fact, I would advocate that you don't. Now, there are many times that you'll talk to our staff and they will recommend letrozole for you for one reason or another. But my opinion is that if you are going to ovulate on your own, as you would any other month, like you do under normal circumstances, letrozole may actually get in the way. And so I would encourage not using letrozole, but then 100% natural cycle, but with a trigger, and certainly using any one of the immune protocols. Now, the one caveat I just want to throw out, when we talk about natural cycles, we're not talking about, well, we throw caution to the wind. We just leave you out there and whatever happens, happens because that's natural, right? No, that's not what it means. We still monitor everything. We still look at your hormone levels. We still look at how what your ovaries are doing and what your lining is doing. And if we need to correct anything, if we need to fix anything, then we do. But it just means that we're allowing your own hormones to participate in the program there. All right, let's take a look at the CNY side and Water the Seed. Hi from Miami. Oh, that's a cool name, Water the Seed. I think I saw some questions over here. Let's see what we can do. Loss, yeah, this comes from Diva Kitty, 55. Loss is the hardest thing to ever really have to go through, and you never completely recover. It is always, that loss is always a part of you, but I do have to say, I believe that that part that remains with us is truly an indelible and very special part that will never leave you. Neva Kitty, thank you for sharing that. Looks like Britt Hendricks on the CNY side. I'm 22 with an AMH of 0.3. Would love some advice. Well, my friend, that constitutes what we call a diminished ovarian reserve. So we're born with all the eggs that we'll ever have. The quantity of those eggs is the very highest at birth. We lose some of them between birth and puberty, but then once we hit puberty, those eggs take on some changes and start to get produced, and we will continue to lose eggs every month. The AMH is considered sort of a qualitative numeric reference for how many eggs we have left. It's not an exact correlation. So I can't say, oh, well, because you're at a 0.3, that means that you have, 1 million eggs left. There's no number specifically that really goes with that, but that is very low for your age. At 22, I would expect, you should really be in your reproductive prime. And with a number of 0.3, that tells me that you are definitely not on the curve there. So my advice for you would be to do something sooner rather than later. Now, people ask me all the time, does the AMH tell me whether I'm going to be able to have a baby? And the answer is no, absolutely not. That's not its intention. That's not what it's for. That's not what it's designed to do. You may be able to conceive completely normally, entirely on your own tomorrow, even a year or two from now. But what it does suggest is that the clock is ticking on the ovaries there. And if you are not ready to be pregnant right now at 22, and that wouldn't be abnormal, I would strongly recommend that you consider doing egg freezing. When we freeze your eggs, we do the first half of the IVF process to rev up the ovaries, get you to produce as many eggs as we can get, which we then retrieve from your ovaries and can store for you essentially forever. Those eggs can hang out and wait for you until you're ready for them. You may not ever need them, but if you do, they're there for you. It's an insurance policy, and you don't know that you'll need them, but in case you do, there they are. So if you're 22, Britt, with an AMH of 0.3, I would strongly recommend do something sooner rather than later. Retrieve those eggs, save those eggs, because they will likely come into use for you in the future. Well, let's see here. We've got some other questions now. Looks like a bunch of folks have shown up on the Facebook and LinkedIn and YouTube side here. Can I take, this comes from Tamara Suarez, good evening. Can I take Plaquenil and Prograf safely together on Immune Protocol 3? We do not recommend you take Plaquenil and Prograf together. They can together have an effect on intracardiac conduction, so the way the heart beats. And so unless it's a special case scenario, and there are some special case scenario where the benefits outweigh the risk, in general, I would tell you Plaquenil and Prograf are not designed to be used together. It's usually Plaquenil or Prograf. Let's see here. What else we have? This comes from KDB. Hello, I had my first failed IUI last month. I'm so sorry to hear that, Katie. I'm in the middle of my second one currently. Do you recommend a double IUI? I'm 29 with an AMH of 10. And what do we say about an AMH of 10? If it's above 5, it suggests polycystic ovaries. And you're right, I'm an AMH of 10 and I have PCOS. I'm doing a letrozole cycle and have 3 potential follicles growing. All right, so the first thing I would tell you is not to be well, gosh, that's easy for me to say, isn't it, right? I was going to say not to be disappointed if an IUI or an intrauterine insemination doesn't work. So in general, the kind of numbers I look at when I think about how these things are supposed to kind of shape up. Home intercourse, for instance, probably confers about a 1%, maybe 2% chance per cycle or per month, per menstrual cycle of a pregnancy. So are you upset if after one single month of trying to get pregnant, you're not pregnant? Well, if you're upset by that, you shouldn't be, because statistically, the odds are it's not going to happen in one single month. Well, same kind of thing happens with IUI. Sometimes people do get pregnant with that first IUI, and I think that's a great thing. But if it doesn't happen, that doesn't mean that something is wrong. That just means that, well, the odds were not in favor of those sperm reaching those eggs, reaching that egg. So the odds of an IUI are probably around 5 to 9%, per cycle or per month, per menstrual cycle. When we look at IVF, we're looking at up to a 60% probability of pregnancy per embryo, and you hopefully have a lot of embryos. So that's one of the reasons that we say, well, IVF is going to be the fastest path to pregnancy and the most efficient path to pregnancy. But it doesn't mean anything is wrong if that first IUI didn't work. As far as a double IUI, we used to think that, so really, and even with home intercourse, ideally, we want to get the sperm to where the egg is going to be before that egg gets released. That's the ideal timing. Remember that sperm probably lives for about 72 hours. So that's why we say really intercourse every other day is all that's required. We used to think that sandwiching the ovulation with an IUI, so an IUI before the ovulation and an IUI after the ovulation, was going to improve the odds. What the data shows us is that it doesn't really increase the odds of pregnancy. So, it is an extra cost. There are some circumstances where I will tell people, I think that you should probably try to do 2 of them. But in general, 1, if appropriately timed with a trigger, and that is where the sperm is arriving before the egg is being released, should be sufficient, Katie, to say that you did everything that you could do with that IUI. So I'll wish you all the best of luck there. Let's see what we got here. This comes from Tiffany. Hi, Tiffany Clark on Facebook. How do you know for sure if you have PCOS, and how does that affect your fertility journey with male factor infertility? So PCOS is an issue with chronic anovulation. So normal circumstances, the ovary releases the egg hangs out and waits for sperm to come along and fertilize it. And if it does, woohoo, the brain says, all right, we're pregnant, we know what we're supposed to do. And if not, it says, crap. Well, all right, shut off the hormones, clean everything out, and we'll start again fresh next month, which is the signal to have a nice normal period. Some people who don't get periods, the reason that's happening is because they are not releasing the egg, and that is pretty consistent with not ovulating, or what we call anovulation. Anovulation is when you don't release the egg. So certainly from a home intercourse standpoint, if you have a male factor, which means that there's a problem with the sperm, be it in the sperm count or the motility, the way the sperm swim, or potentially in the morphology, the way the sperm are shaped, well, that means there's going to be an issue with the sperm getting there. And if you're not releasing the egg because of PCOS, then you've got kind of a double whammy situation there. Now, depending on what the sperm situation looks like, sometimes you can do intrauterine insemination. And in that situation, a partner gives us sperm. We are able to separate out the best and the strongest swimmers so that we can place them inside at just the right time in order to try to maximize the opportunity that sperm is going to be able to meet egg, especially when we do like what we're doing there. When we induce your ovulation, we make sure that your ovary is going to release the egg so that we can put the sperm right back in. Well, in the IVF world, the male factor is pretty easy to overcome because we really only need 1 sperm for each egg. So somebody sits by a microscope and selects out each sperm for the eggs that they've been able to retrieve. Now, the stimulation in someone with polycystic ovarian syndrome means that you have a tendency to produce a lot of eggs. So we tend to err by turning down the amount of medication that we would otherwise give you, because quantity of eggs does not always equal quality. Really what we want is the egg quality. We don't need you to make 80 eggs. It is just not necessary. Anything more than about 15 does not improve the outcomes. So that's sort of how it's affected. We changed the medication, and certainly from a home fertility standpoint, having both PCOS and a male factor can be a couple of obstacles that you have to overcome. Hey, Tiffany, thanks so much for being with us here tonight. Let's see here. Journey with the Robersons. Hello, Robersons. I had a laparoscopy in September and a hysteroscopy in April. CNY wants a hysteroscopy done in August to check for polyps. Should I push for another laparoscopy as well and just get it all done? You know, if you just had a hysteroscopy in April, my first question would be, do you really need to have another one in August? And I think part of that depends on what was the reasoning there behind having to, what was the reasoning there behind having that first hysteroscopy? Because if you had polyps removed, you know, I'm not sure that you need another one quite so soon unless there's a real reason to have to check back and do a second look. Now, sometimes that will happen because you had some scar tissue and you want to check and see if the scar tissue is gone. But I would really ask the question, make sure whoever suggested that you have that repeat knows that you just had one a few months back. That concerns me a little bit there, Robersons. Should you have another laparoscopy? Well, that first laparoscopy was also, you know, getting to be about a year ago. And my question would be, did they find anything? So if you had pretty significant endometriosis, you know, when you had that laparoscopy, it might make sense to take another look and see if there's any more endometriosis that can be cleaned up, especially if you're having symptoms, especially if you're uncomfortable, you have painful periods, all the things that kind of go along with symptomatic endometriosis, which can be painful sexual relations. It can be pain with bowel movement. So these are the kinds of things I'd really want to know. If your laparoscopy was completely clear last September, I would not favor you having to do another laparoscopy. I don't think it would really add much to your success. Let's see, looks like BJ Pumping said, I had my consultation and they suggested PRP. So ovarian PRP is where we take your body's own healing tissue, your own growth factors, and place that right into the ovaries, which can help with things like egg quality. So Nurtured Shanna there says, I know running and other high intensity exercise is not recommended during stimulation. Are there any issues with running before a transfer and stopping after the transfer? I would say no, no real issues there. So you're right, during the stim, we probably don't really want you to do it because, you know, your ovaries get really big. And so you can get yourself into a situation where that ovary wants to shake up to the point where then it twists, and that can become a surgical emergency. So during a stimulation, that I wouldn't say that's the best idea, but certainly before a transfer, Shanna, I think that is a great idea to kind of keep yourself healthy. But again, my heavens, hats off to those people who can go running at this time of year because it's pretty hot outside. Okay. Can I use gonal and a trigger instead of letrozole and a trigger? I ask because with letrozole, my lining gets so thin with it. So this is from Maile. I think you're talking about for something like an IUI or trigger letrozole and a trigger. I think that your situation is that you're talking about for an embryo transfer cycle. Because I believe you already have your embryos. Yes, you can use gonadotropin to help stimulate the ovaries. Letrozole sometimes can have an effect on the uterine lining, just like Clomid. Clomid almost always has an effect on the uterine lining, and so that's why we at CNY typically don't use it. So yes, you can, but just once you start using the injectables, the cost obviously goes goes way up. This comes from Rachel at Facebook on the Facebook side. Hi, I did your retrieval. Oh, good. All went extremely well. I'm so glad to hear that, my friend. We had 6 blasts that we sent for PGT and did a transfer with 1 euploid from those. We did a natural transfer with an HCG trigger. Sadly, it did not work. What can I do differently for this next transfer to try to have success? 30. You're with no obvious fertility issues except that you had your tubes tied in 2015, and that's why you're doing IVF. Rachel, it's a good question. You know, same thing there, I would say, like we mentioned before about the IUI, and that is, you know, it just doesn't always work the first time, and that doesn't mean that anything is necessarily wrong. So I do favor the natural cycle with your euploid embryo. Right, you have about a 60% probability of getting a positive pregnancy test, and that's the best that we can offer with IVF. But 60% probability means that there's probably about a 40% probability that it's going to end up being negative. But even though these two things are not additive, so 60 and 60 equals 120, and so it's kind of not possible to have a 120% chance of pregnancy, we generally suggest that you have 2 euploid embryos for each baby or each child that you'd like to have. So the fact that the first transfer didn't work only suggests to me that there is a significantly greater probability that it's going to work the second time around. As I said, I do favor the natural cycle, and so I would recommend that you stick with that. Sometimes we do step up the immune protocol just in case there's something immune that's in the way. So Rachel, if you were doing immune protocol 2, you might ask about immune protocol 3. This comes from Anna. Hi, Anna. Nice to see you. I recently had my second transfer of 2 day 3 embryos. Would you recommend the ERA, Emma, and Alice? So that test is also called the endometrio. And before I answer that, I just want to say one thing to the folks who are on the CNY Instagram side here, and I see there's a bunch of people in there. And I still have a bunch more questions over here, but I have to admit, it looks like the iPad with that has about 2% of battery left. So something happened. It went from 70% to 2% in the 37 minutes that we've been on here. I don't know that that 2% is going to take me through the next 20 minutes. So if you want to slip away from the CNY side and join me at Randy Fink MD, very easy to do, Randy Fink MD on Instagram, then you will get to hear the wonderful remainder of our talk tonight. By the way, we are live from Miami, Florida, and it's about 20 minutes until the hour, and you're on Fertility with Fink and Friends. I'm Fink, you are friends. And now, Anna, the endometrio, the ERA, the Emma, and the Alice. Do I recommend it? So the endometrial receptivity assay is no longer considered a great test because when they studied lots and lots and lots of transfers, they found that people who did the ERA were no more likely to have a positive pregnancy test than people who didn't. The M and the Alice is an interesting thing because it may show us some specific organism that's causing an inflammatory response in your uterine lining. But it's not a test that I routinely recommend anymore, especially after day 3 embryos, because with day 3s, we never really know what the situation is. Now, someone who has had recurrent implantation failure with, let's say, euploid embryos, which we know have a very high probability of achieving a pregnancy, well, then I might consider recommending the test because to me, it kind of makes more sense under that scenario. So best of luck there, my friend. Let's see if I can get to a couple of Instagram questions here before we lose the battery on that side. And again, still about 2%. Randy Fink MD is my Instagram. Just switch right over there and we'll be here until the top of the hour. Joanne Joe 101 from Montreal. Good evening. Love you guys. Thank you. Well, we love you too. Montreal is a great city. How long should I take melatonin before starting my IVF long protocol? I would recommend that you stay on melatonin up through the time of your retrieval. So the data shows us that melatonin is found present in the fluid that surrounds the egg. So improving melatonin levels can also improve egg quality, and egg quality is really probably one of the most important things that we can try to focus on. So good question about melatonin. Thank you for actually taking it. Let's see here. Is it risky to come off progesterone at 12 weeks? This comes from Haley. Hi, Haley. No. So, when we do IVF, we give you extra progesterone because we're trying to support the hormone that your body needs in order to maintain the pregnancy. When we've done a medicated cycle, we have to give you that progesterone because your body has not released an egg. If you're doing a natural cycle, well, then your body has released an egg and you will be making some of your own progesterone there. So that's why with the medicated cycle, you do the progesterone in oil injections, whereas with the natural cycle, we just use a little local progesterone, a vaginal suppository. What I would tell you is that at about 9 weeks of pregnancy, your placenta takes over. And when the placenta takes over, then that means it's making its own progesterone. And so really at that point you can stop. So there should not be risk for stopping that progesterone at 12 weeks because your body should be making enough of it at that time. Oh gosh, this makes me so nervous. There's 1% left on this iPad here. So if you're on the CNY Instagram side, please switch over. Randy Fink MD, CNY's Instagram is about to go dead for this live presentation, but switch to Randy Fink MD and we'll be able to finish in the last 15 minutes or so. Let's take a look here. And so if it shuts off on you, then I'm going to go ahead and say thanks for watching over there. Okay, wow, that was really strange. Lost everybody there. Okay, this comes from Caitlin on the Facebook side. After being diagnosed with a hydrosalpinx, what's the recommended next step? And is conceiving with an IUI or naturally, if I ovulate and the partner's sperm is great, needed without IVF? Well, so in the presence of that hydrosalpinx, which is a tube full of fluid, I would recommend that you remove the tube because the fluid that's in that fallopian tube contains fluid that fluid that's in the tube can be toxic to an embryo. So as it leaves the tube and washes back into the uterine cavity, it can kill an embryo. So we strongly recommend that tube, which is not functioning anyway, it's not doing anything for you being there full of fluid, we recommend that tube come out. So that's really probably the best thing that you can do, Caitlin. And if you do that, then certainly an IUI or even natural pregnancy, without one tube, your fertility is largely not affected. So I think that you can still be pretty confident as long as that other tube is working. You should be able to continue to try to conceive naturally, which would be just fantastic. This comes from Dr. Michelle Harvey. Hi, Doc. I had a tubal ligation in 2012 in a bad marriage. I got remarried and I want another child. IVF versus tubal reversal. Well, the answer there is tubal reversal is where we can remove the segment of tube that's been damaged by the portion that was removed and try to sew them back together. Sometimes this works and sometimes it doesn't. When it does, Great, because then you return to normal fertility just like everybody else. A lot of the answer to that question, Doc, has to do with your age. So, and how likely IVF would be to be successful. Now, in the CNY situation where IVF is so very affordable at the lowest cost IVF in the country, it is going to cost you probably far less to have a cycle of IVF than it is to get your tubes reversed in most places, because that surgery is not covered by insurance, and is going to be cash pay. So if you are of an age where IVF is likely to be successful, then it may be more beneficial and quicker, certainly a faster path to pregnancy, by doing a cycle of IVF, making some embryos, doing an embryo transfer, and getting pregnant. If IVF is less likely to be successful, then maybe you want to think about having the surgery, because then you can continue to have home intercourse and try natural pregnancy, really, honestly, for the rest of your life. So, Doctor, I hope that is helpful. Well, there we did. We lost our CNY Instagram side. So hopefully folks were able to join here on the Randy Fink side, because it's 6:46, which means 14 fun more minutes from Miami, Florida, where I'm sweating here, man, because it's, I opened up the windows here to see a little sunshine, and boy, it has heated up pretty quickly. I'm going to forget what this is like. This comes from, well, I think that's Caitlin. I think we answered you on Facebook. You asked on Instagram as well. Is an office hysteroscopy painful without anesthesia? I think that, and this comes from IXOXO_U, and I am not even going to attempt to try to pronounce that, my friend. A hysteroscopy is crampy. The little tiny camera goes through the cervix, and when something goes in the cervix, it can cause a little cramp in the uterus. In order to see with the hysteroscopy, we put some fluid inside, just some normal saline, which circulates around and lets us see what's going on inside the uterus. Now, when I look with a hysteroscopy, that procedure should take, honestly, seconds. It should be, in most cases, can be finished in under 30 seconds. Can do it quickly as long as there's nothing there that we need to see, that we need to treat. We can look pretty quickly, and then it's done and over with. It's crampy. I suppose it really depends on your tolerance for such things. In my opinion, life is too short to cramp. So I always offer folks anesthesia, because it's so easy for us to do. We do it in our office. You get a little sedation. We get the procedure done. You don't have to feel anything. You don't have to worry about anything. Yeah, it takes a little longer, and you can't have anything to eat or drink after midnight. So, it becomes certainly a bigger production. I see there being no harm in doing an office hysteroscopy. I've done thousands of them in my time. I think it really depends on the individual's tolerance of cramps. But given that the procedure is very, very fast, again, should be done certainly in under a minute, but more likely under 30 seconds, it's certainly a doable thing. I see my friend Daisy made it over to Facebook. Thanks for being here, Daisy. Erica Smith is asking the percentage. I'm not sure where we're going with that. The percentage and time it takes isn't worth it. Go straight to IVF. I think she's rendering an opinion to Dr. Michelle, who was asking about IVF versus tubal reversal. Toyin is asking, how accurate is a PGT test? PGT. PGT is pre-implantation genetic testing. And depending on what we're talking about. So for gender, PGT is very accurate. But what's happening with PGT is that we grow the embryos to the blastocyst stage. And a blastocyst is typically a day 5 embryo, sometimes day 6, sometimes day 7. And then the portion of the embryo that is going to become the placenta is what's biopsied. It is possible to have a normal placenta and an abnormal embryo. And that's one of the reasons that a PGT tested embryo can still result in a miscarriage. But by the same token, it is also possible to have some discordance or a disagreement between the placenta and the embryo, where the placenta is abnormal. And so the PGT comes back and says it's abnormal, but there still may be anywhere from a 5 to a 15% chance of having a normal baby. So it's not a perfect test. And when we offer it, I generally think the best reason to do PGT testing is to take a large group of embryos and to try to statistically whittle down which of those are more likely to get you a pregnancy, because we can safely say that with a PGT tested embryo, that's going to give you about a 60% probability of pregnancy, which again is the best that we can offer in IVF. So if you have a large group of embryos, you can narrow down the group that's more likely to get you pregnant. And that, I think, is really the best use of PGT. Danae Wolf is here. Hi, Danae. Nice to see you. Today was baseline for an egg retrieval. Your lining on cycle day 3 is 11.5, and the bleeding seems to be mostly done. Should I continue or take progesterone for another bleed? Well, you answered my question. Are you planning to do a fresh transfer? If you're planning to do a fresh transfer, starting out with a lining of 11.3 is too thick. That tells me that that lining is not going to be healthy enough for a fresh transfer after your retrieval. So you can do one of two things. You can get on some birth control, which will hold things off. You can wait. It's only cycle day 3, so we still have a couple of days before we would otherwise start stims. So depending on kind of what your other numbers were, we can just take a look in a couple of days and see if that lining has thinned out. Alternatively, you can say, well, I'm gonna take some progesterone, which is gonna kind of give me a nice clean out, and then I can kind of start again from there. So you do have some options, but one of them is not proceeding. Please don't proceed if your lining persists at 11.5 for that egg retrieval if you're planning to do a fresh transfer. It looks like Erica is, thanks for chiming in here, talking about doing the office hysteroscopy. Was slightly uncomfortable, but if you take ibuprofen or something, I was uncomfortable for the rest of the day, but not miserable. It depends on the sensitivity of your cervix. And I do think that that's a very important point. I would absolutely positively, under no circumstances, recommend that you do an office hysteroscopy unless you have pre-medicated with some anti-cramp, which means you take some ibuprofen. And I say if we're doing that in the afternoon, take it with your lunch. If you're doing it in the morning, take it with your breakfast. It's kind of a little bit better if you get it with some food, and that will go a long way towards minimizing cramps. Erica is over here, and Erica was in love with a modified natural cycle and transferred with Brandis today. So thanks for that, Erica. I am sure, I don't know if Brandis is on anymore because she was on the CNY side, but I know she says hello and all the best of luck. Sherika is here and said, I did my egg retrieval on Monday. I'm 35. I have 3 embryos. We had male factor. Is an HCG wash a standard, or is it something that I have to ask for? And with this being my first transfer, is it possible to transfer 2 embryos? I'm doing acupuncture or anything else I can do to increase my chances. So an HCG wash comes as a part of our immune level 2 protocol. It is something that anyone can do. And usually what will happen when you are calling to schedule your embryo transfer, the nurse should ask you, would you like to do an HCG wash? They're done in the clinic, typically 1 to 2 days before embryo transfer. I do strongly recommend it. It sort of turns up the volume knob on some of the receptivity proteins in the lining of the uterus. It improves the odds of that embryo wanting to take up residence there. So I would, as far as transferring 2 embryos, So we typically recommend that you go by the ASRM, the American Society of Reproductive Medicine guidelines, which would suggest that you not transfer 2 embryos at 35 because the odds are still reasonably good that you will achieve a pregnancy. And we really want you to have a pregnancy, 1 embryo, or rather 1 baby, 1 healthy baby at a time. Increasing the number of embryos transferred does not necessarily improve your birth rate. It may increase the probability of a positive pregnancy test, but doesn't increase the probability of live birth because it increases the risk for pregnancy complications that can actually result in pregnancy loss. So routinely as a first transfer, transferring 2 embryos would not be something that I would recommend. So let's say hi to Amber, who joined me here on the Instagram side. Nice to see you, my friend from Kentucky. Mrs. Laura Moore had a second laparoscopy done where they found endometriosis on the right ovary and behind both ovaries. Could endometriosis be the reason behind PCOS and or eggs not maturing? Well, endometriosis doesn't relate so much to PCOS, which is more of a metabolic type issue, but those with endometriosis can have issues with egg quality. Typically when we talk about eggs not maturing, that sounds like it may be more of an egg that's retrieved from a small follicle or a trigger that might have happened a little earlier than optimum. But egg quality, yes. And so the interesting thing there, Laura, is that I think you're suggesting that the first time that you had a laparoscopy, they didn't see endometriosis, but the second time they did. And that's an interesting finding. And it goes back to what we were talking about before. Is it worth doing a second laparoscopy for the person who asked, who had one less than a year ago? And I would still say, I think the answer there is not necessarily. Let's see. Oh, Brandis is over here, so she may have. Oh gosh, and I've got Daisy over here. Well, I got everybody on the my Instagram side. Hopeful in 2023. That is a good name. You had your retrieval on May the 9th, then had a period from the 15th to the 19th, but haven't had one since. Should I be concerned and look at having a period induced or just keep waiting? Well, so, you know, what's happening there, we talked about it before, when the ovary doesn't release an egg, then you don't get the signal. And if you don't get the signal, there's no period. Should you have that period induced? Well, I suppose it really depends on what you're planning to do. My friend, if you know, you're waiting for that period because, for instance, you're going to do another egg retrieval, well, we may not have to wait. Or if you are doing, you know, waiting for it to do an embryo transfer, then yeah, go ahead and you can have a period induced. We use progesterone for that. You can have a PIO shot, or you can take a few days of some oral progesterone, and that will cause you to slough off your lining and reboot the system. So it really kind of depends. But if it's just because you haven't had the period yet, I would want to know, do you normally, would you otherwise, you know, be getting regular normal periods? And if that is outside the norm for you. So that's my thoughts there. Hey, listen, folks, we got about another 2 minutes here. So let me see if I can get in another few questions. Oh, look here, Erica, Brandis, I hope you're listening, because Erica is saving. Brandis, you are all great. Brandis is so sweet and did amazing. Hey, Erica, really, you know, we live for that kind of feedback, to be honest with you. It really means the world for us to be able to have this kind of impact on your life. Nicole on the Facebook side, excited to start IVF in Colorado in September, and we are just as happy to see you. Junae is asking, how will I know that letrozole has affected an IUI cycle? Well, letrozole is going to make you ovulate. So when you are being triggered, that means that you're ready to ovulate for some reason. So you created an egg, whether it was on your own or with the help of the letrozole. So that's how we know it did its thing. Well, folks, I think we're going to have to wrap it up here because these are kind of going into questions that are taking me a little bit longer to answer. I really want to say thank you so much for being here live from Miami tonight. Next week, we're back in Colorado with Fertility with Fink and Friends every Tuesday at 6 p.m. Eastern and 4 p.m. Mountain Time, which means 3 p.m. on the West Coast and 5 p.m. for the Central Time. Infertility is not your book. It is not the title of your novel. It is not your picture on the cover. It is only a chapter, and it is a chapter that we are really enjoying trying to help you rewrite. So to everybody, thanks so much for being here. God bless to all. Best wishes, and we'll see you next week. Good night.